The amount of pain I was in, I went white, I was sweating, I thought I was going to pass out, I thought I was going to throw up. Like the whole experience of it was intense.
Like a painful position to be in, like it was a constant pain, and like if I moved the wrong way, then I'd have a back spasm that would be very painful. Very annoyed that I wasn't able to use my body in the way that I normally do.
Back pain's a very common presentation in the emergency department. Usually can't fix quickly. And people really are often at the end of their rope thinking, I need something to be done and I want to go in there and help them. And often I have that frustration, that sinking feeling, because I know sometimes I can't help them right then and there.
The GP said to me, like, you should go to emergency and they'll give you some scans, like that was his plan. He said, look, I want you to, maybe you should go and do an X-ray at least and have a look at it.
Provide them some blood tests and some kind of safety of blood tests or safety imaging. It makes us feel better. I think as you become more experienced, you realise it's probably not the appropriate way of going. It's actually more time, and speaking to patients can take away some of their anxiety.
Talking to the patient, exploring their fears, exploring their beliefs, providing them the knowledge they need to take control over their situation and their pain can be a better analgesic tool than providing medication.
Yeah, I think once you're out of that fear part of it, where you think you've done like the worst thing in the world and how could you have damaged yourself, and the reality sets in where it's actually not too bad and it will get better and settle down, I think having more information around that is better.
Usually when patients go to the AD, they often miss out on the basics of care. They usually don't receive appropriate education or advice, reassurance, things we know that really work and improve the patient outcomes and decrease the distress and decrease the pain levels. And also we know that very rarely patients encouraged to remain active and do more physical activities.
I physically help them to get out of bed and I tell them, look, I know this is painful, but this is actually going to help your pain get better. We'll be there every step of the way. We will help them get through this, and that actually walking is probably the best thing for their back pain.
The more you think that's wrong with you, the less effort you might put in, because it might hurt, you might injure yourself, you might do all those things. But it's a real move it or lose it situation.
When it was the most intense, best thing to do for me was to just move around the house, walk, just keep moving, and that kind of like moves your body a little bit, and it doesn't lock up. So
the key thing would be is to remember to do the stretches, which is what I'm doing now, and the strengthening exercises. But also, I now walk to and from work, for example. And I do that because it's really nice to have a break between work and home. Carry a really light backpack, I feel better, my muscles are warm, and so when I go to do my stretching in that, I feel much better.
So I think having close early follow-up reassures patients that they're not being ignored. And I think that's some of the anxiety is there something bad happening? Will I require an operation? And having a senior clinician reviewing them early also gives reassurance to the emergency medicine staff that they don't need to do a lot of tests.
He kind of just reassured me that, from, the series of questions and the physical tests that he put me through, that, there wasn't any serious damage.